Hey everybody, this is going to be a pretty short and sweet lecture today. On Thursday, we will start getting into some of the lab stuff, so I'm going to stop after this sort of intro section and then we'll pick up with the specific techniques on Thursday, and then we have a whole lab day devoted to this on Friday. And we're talking about mobility, and before I do that, I have to ask you, what do you call somebody who's afraid of Santa? Claustrophobic. Ah ha ha ha. All right, I thought that was funny, even though it's not seasonally correct. So, anyway, all right, let's talk about mobility. So, we talked about that mobility is the base of the pyramid. And because I'm back on my laptop and I figured out how this whole thing works, then look at this. Ooh, I don't have to remember to select the pen anymore. I can just use a little keyboard shortcut, which is awesome. So, anyway, talking about the base of the pyramid here, if you can't move a joint segment or if you can't move a body segment, then the amount of strength that it can produce is potentially going to be limited in its functional application, because if you can't move it, you may be really strong still and you may even have a lot of endurance, but if you can't make this connection here for function and mobility, then you're a little bit stuck. What influences joint mobility? So typically what you're going to end up seeing is somebody who has had a period of immobilization. So they've had surgery, they've had injury where they've been casted or they've been in a splint of some sort for 2, 4, 6, 8 weeks, who knows, or somebody has been on bed rest for a given amount of time, or they've been unconscious in a coma and so on. So immobility can happen. When somebody is immobilized, then you get changes in the tissues. So remember, your body is inherently quite lazy. So if you're not using it, you will lose it. And when you are immobilized or you're not using a body segment very much, then those tissues can shorten up. And you also lose neuromuscular control. So those patterns of movement aren't being used very often. Those kind of connections in your brain aren't being made as often. So they start to not be able to connect as well. You don't have that same amount of neuromuscular control. And here I put a few notes. When we talk about tissue shortening, here when we're talking about the interior structures, what I mean by interior structures is that's where you're talking about some of the things like tendons and muscles, joint capsules. So kind of all that interior tissue that surrounds a joint that can become shortened. When we're talking about exterior structures, then we're looking at restrictions in the skin. So if somebody have a scar or a burn, or an area where it's painful for the skin to move, you can have excess body fat or adipose tissue that's in the way. If you have a physical block for that movement because there's excess tissue, then you have a limitation in movement, and then you can have changes in the muscle that are restrictive, even though they might look good. If somebody has a lot of muscle mass, and so then they can't bend an elbow all the way because of their giant biceps, or they can't get their arms all the way up overhead because of giant traps and deltoids, that can happen. With neural restrictions, so when you have a nerve, change colors here. When you have a nerve, so here's your nerve fiber. It doesn't matter if it's myelinated or unmyelinated right now. When you have your nerve fiber, then surrounding your nerve fiber, remember, is going to be a sheath. And that nerve has to be able to move freely within the sheath. So if the nerve is not able to move freely within the sheath, the nerve's going to get irritated. It's going to send inappropriate pain signals, or in this case, appropriate pain signals, because it's not supposed to be working that way. And you end up getting pain because that nerve isn't gliding appropriately in its space there. Other things affecting joint mobility, remember, if somebody has pain, they're not going to want to move the segment voluntarily. And also you can get muscle guarding. And a few of you were able to feel what muscle guarding feels like during lab last Friday. I know we had a couple folks where when we did the cervical flexion test, you would feel some muscle guarding in those neck extensors, because when it hurts to bring your head forward, then those muscles are going to contract to try and bring the head back to where it's not painful. So those two are going to go together. If you have swelling, swelling is painful because you have excess pressure inside the joint and that hurts, but also swelling can influence joint mobility because you get back to here, some of this exterior structure. The skin is sort of stretched out. It's all blown up like a balloon. As you move it, it feels sort of tight, and then doesn't end up being fat, but you also have some of this same type of thing where if you have a bunch of swelling in a segment and it's taking up space around the joint, then when you move it, there's going to be that swollen tissue in the way. Muscle spasm that can go along with guarding. Guarding, we're kind of referring to when you do a motion and then that muscle kind of twitches out. Spasm is a sort of maintained, prolonged contraction of the muscle that is painful. And remember, we've talked about this somewhat ad nauseum now, the difference between tightness and hypertonicity. So a tight muscle can be actually shortened. You have a tissue shortening, or hypertonic, where you're talking more about guarding or a muscle spasm. When we're talking about the receptors that communicate some of this, the Golgi tendon organs and the muscle spindles, with your Golgi tendon organs, remember they're going to communicate the amount of force and the rate of change in force that is occurring in the muscle. And the muscle spindle is going to indicate the amount of tension and the rate of change in tension in the muscle. Doesn't want to dot my I. There we go. So long story short, or short story long here, what can influence joint mobility? If the person has pain, if there's swelling in the joint, if there's guarding of the muscles or spasm of the surrounding muscles, that muscle can either also be restricting movement because it is actually shortened. We're here into tissue shortening. That would be an interior structure. If you have changes in the exterior structure, that could be swelling again. The skin's stretched out. There's edematous fluid in the way of movement. Or if you have someone who has a scar or a painful skin tissue area that they don't want to move, that can influence mobility. And you have neural tissue restrictions when that nerve is not gliding appropriately within its sheath. Flexibility, range of motion versus stretching activities. They have two different therapeutic reasons. So range of motion, we're talking about the movement through available non-restricted range. So the important point here, that this is the non-restricted range. When we're talking about range of motion, non-restricted. You're moving through the range of motion and you are trying to just move through what is available. You're not trying to move beyond that. When you're talking about where do you stop, we usually say at the point of tissue resistance. So once you feel like there's something stopping you from doing that movement, that's where you stop. That's your range of motion. That therapeutic technique, if you're not trying to improve range of motion through lengthening of a tissue or getting a muscle to relax and cooperate, and you're just doing range of motion, you're moving to the point of tissue restriction and not past. Range of motion is usually for maintenance of joint motion, for preventing loss of joint motion, where stretching is to increase range of motion. So when we're talking about stretching, Then we're going past the point where resistance is felt to the point of mild discomfort. So range of motion, it's non-restricted. You're moving to the point of tissue resistance. Stretching, you are moving past the point of tissue resistance to the point of mild discomfort. Oh, really awkward pause. Sorry, because I didn't do this. Hold on. Now, flexibility involves both of these. So flexibility is the ability to move a joint or joints through a full, non-restricted, pain-free range of motion. So you have, for flexibility, the ability to move a joint or joints through a full, non-restricted, pain-free range of motion. The ability to move through a full, non-restricted, pain-free range of motion is going to depend on the arthrokinematics of the joint. So you have a wealth of knowledge now from DBJ about how your joints are put together. So think about, what is the shape of that joint? What is it going to look like when you're moving through the range of motion? Is there going to be a bony block at some point? So on. And tissue elasticity is somewhat what we talked about in the last slide. So how much play do you have in those muscles and in those tendons, in those nerve sheaths? How much play is there to be able to do the normal motion? And then remember, accessory joint motions, that's going to be, if you think about your joint mobilizations, or doing some of those joint glides that you learned when you're looking at a joint play assessment. You'll learn more about that coming up. But the ability to get your finger joint to slide side to side. So if, let's say, this is your distal phalange, here's your knuckle, and here's your proximal phalange. So you can you can flex and extend your finger, but also your finger will bend this way and that way. You can't do it voluntarily. You're going to have to push on it with your hands, but there is some play in that plane of motion. You have to have that accessory joint motion to be able to do the flexion and extension movement easily. And the question always comes up, is this correlated with performance in a sport? It's not necessarily correlated with sport performance unless it's something that is required for the sport. So gymnastics, diving, those sports where you're bending yourself into strange shapes. Then flexibility is going to benefit you in your performance. Hurdling is another one, and high jumping and pole vaulting, where you have some more bodily contortions that have to go on to actually do the sport. So then, yes, flexibility is correlated with sport performance, but otherwise it is not correlated with sport performance in other sports, say basketball, tennis, and so on. The other question is there a correlation with injury prevention? It is not necessarily correlated with injury prevention, except for cases when there's a high velocity, high magnitude force application and somebody has a true tissue restriction, where this is most often seen if you look at Achilles tendonitis, and over time with chronic Achilles tendonitis, you get that chronic buildup of fibroses and kind of a weak cartilage, or weak cartilage structure that's not very flexible. And so when there's a high magnitude, high velocity force application from jumping, landing, etc., then you can have an injury occur. But in general, people who are more flexible are not injured more often than people who are inflexible, and vice versa. Then I want to point out that there is a difference to remember between dynamic and static flexibility. When we're talking about dynamic flexibility, we're asking, is the muscle moving the joint? Versus static, or is in static, then the joint is being moved passively. So this is sort of your voluntary range of motion. This is your assisted or passive partner stretch type of flexibility within a joint section. You guys are going to learn goniometry in 412 in your tests and measures class. There is a norms table in your book. It's on page, I'm sorry, I don't know what page it's on, but table 8.1 has some norms for range of motion for different joint segments. So if you need a little cheat sheet for 412, you can use that. All right, how do we actually improve joint mobility? We talked about the principles of training. Remember, we talked about the overload principle. So if you are overloading a system, it has two options. It can either adapt or it can fail. So with improving joint mobility, we definitely want the system to adapt. We don't want the system to fail. If the system fails, that means something's torn or strained or unhappy. So we want to have the system adapt. How do you make the system adapt? You have to push the system beyond what it is currently doing. And the more you push the system beyond what it's currently doing, the more improvement you'll get, or the more change you will see. The goal of improving joint mobility is that you're altering the extensibility of the neuromusculotendinous units. So it's not just about the elasticity or flexibility of the muscle or the tendon or the ligament or the joint capsule. It's how that feels and how that all gets communicated back to the brain, how the body reacts to it, and so on. So when you are doing some stretching, and in particular, we'll talk about doing PNF stretching. This whole concept of tolerance to stretch becomes important, because are you always changing something about the collagen structure? Not necessarily. You may just be improving somebody's tolerance to what stretching feels like. So you get into that neural input, you can kind of fatigue out the stretch reflex so that it stops reacting so strongly. And that improves somebody's joint mobility, not because you actually changed the length of the tissue at all, but because they're more tolerant to the stretch. Remember that most of what we're talking about is going to be made of collagen once you get beyond the muscle itself. One thing you should note is that contractile elements of a movement are going to stretch first. So if you have, if this is your stretch that's going on, with to the right being more intense and to the left being less intense. So first you have this, we call it the toe region. And in the toe region, everything's kind of relaxed and you're just stretching it to the point where then everything's lined up. So remember, you have your actin and myosin that are overlapping. And I'm not sure if I'm quite good enough to draw that on this, but we'll make an attempt. So if you have your units that are just sort of in parallel and relaxed, remember that these are overlapping. But when you start to stretch, the first thing that's going to happen is that then those are going to move outwards, and you're going to have an actin and myosin not overlapping. So that movement from overlapping to non-overlapping, that's here in the toe region. Once you have maxed out that change, then you get into some of the properties of collagen. That's what's going to be in your tendon, ligaments, joint capsules, and such. So elasticity, If you look here, this is the elastic region, and that means that it will stretch, and then when you take the force away, it will bounce back to what it looked like before. That's the elastic region. Plastic region, when you have a plastic change, that means it stretches, it gets a little longer, it stays that way. It doesn't bounce all the way back to where it was before. Once you get past the plastic range, that's where you end up at the point of failure. So that's their little drawing that the material has failed. So what we're trying to go for, if you're trying to increase the extensibility of a tissue, we're trying to get here into the plastic region. You want some of those changes. All right, what is viscoelasticity? Viscoelasticity means that the material has viscous properties that change with heat. So if you think about the difference between cold gravy and warm gravy. So go back to Thanksgiving and think about, what does gravy look like when it's warm in the boat and you're going to put it on your mashed potatoes. It's kind of nice and runny. Versus when you put it in the refrigerator for leftovers, when you go to take it out, it's kind of like a jelly, not flowing substance. It's like really weak jello. So that's viscoelasticity. It has viscous properties that it changes with heat, typically meaning that when it's colder, it's thicker, and when it's warmer, it's thinner. So viscoelastic properties of collagen exist, meaning that warmer collagen is more elastic than, or more able to stretch before reaching the failure point than cold collagen. So it's one of the reasons that we heat tissue before we stretch it. Force relaxation and creep, those sort of go together. That this over here is an example of creep. So I'm having a hard time seeing what the force was here, but I believe this says 30 pounds. So there's 30 pounds of force put onto this muscle. So first it's going to stretch through its elastic region and kind of hang out there. Everything's just unwound and we're hanging out with our 30 pounds. Then this is still 30 pounds and this is still 30 pounds. But over time, as that same force is held onto that tissue, it starts to get longer. So even though it's the same force, over time, the tissue starts to lengthen even more. So that's that's creep. And with force relaxation, this can occur in the body, especially if you have somebody with a postural issue. Then in particular, you see this, and you may have seen this with some of your classmates last week, is that people who are very forward head and rounded shoulder, they have some force relaxation in their thoracic spine because their scapulae sit pretty far forward. And you can get some creep in those ligaments and tendons and muscles because you have that constant force pulling it forward or pulling in one direction, and eventually that tissue lengthens out. Hysteresis, the best way to describe it is like a rusty gate. So when you open a rusty gate the first time, it creaks and squeaks and it's difficult to open. But then as you open and shut it a few more times, it sort of knocks the rust off and it's a little bit easier to move. That's the best way to describe hysteresis. It incorporates viscoelasticity, that as the tissue warms or the material warms and moves more, then it's easier to move. What do you need to know about agonist, antagonist, and synergistic pairs? Your book does a nice job describing this. And the best example that they give is with the psoas. So if the psoas, remember that's going to be here on the anterior portion of the pelvis, is hyperactive, then you get a decreased neural drive to the glutes. That's your plain old reciprocal inhibition. This muscle is tight. This muscle is hypertonic. So it's going to tell the other muscle, we're contracting, so you should relax. So if you're contracting here on the anterior pelvis, posterior pelvis is going to relax. So long story short, changes in one muscle group are going to influence other muscle groups. And when one muscle group is inhibited, so we say that the glutes are inhibited, then you still have to have something to stabilize the pelvis. So then you get overactivity in the other hip extensors, so hamstrings. You get substitution by erector spinae because they can also pull on the pelvis and try and keep it stable. So overactivity usually is present when you have a substitution because it's not the muscle's usual mode of activity. So it has to work a little bit harder than it would to do its usual job. And you get overactivity in those substituting muscles. You also have joint stresses. Remember that, for example, your head weighs about 8 pounds, but the further forward it goes, the heavier it is to your spine because you're taking that point load and you're moving it anterior to its base of support. So you're going to have joint stresses that will change depending on which muscles are active, which muscles are tight or hypertonic, and so on. But the better that a body segment does at stabilizing with surrounding musculature, the less stress there is on a joint. So the better off you are with having good deep cervical flexors and nice relaxed and well-positioned upper traps and levator scapulae, your head sits in a better position and therefore you have less stress and strain on those joints. And stretch weakness goes back to what we just talked about with force relaxation. So if you have this scapula that's sitting really far forward, then you get that stretch weakness because of that force relaxation in the thoracic spine. Here I put another example. This is called Janda or Yanda. I'm not sure how you are supposed to say that, but it's Janda. Yanda's upper crossed syndrome. That was upper crossed. There's also a lower crossed syndrome, but it kind of goes along with that. So upper cross syndrome basically states that you have tightness or hypertonicity in the upper trapezius and levator scapulae that are pulling up. You have tightness or hypertonicity in the pectorals and sternocleidomastoid that are pulling down. That's going to be compensated for, I said that incorrectly. I apologize. So you have tight upper traps, tight pectoralis, and sternocleidomastoid because you have weakness in those deep cervical flexors and weakness in traps and serratus anterior. So because the serratus anterior and traps aren't holding the scapulae where they're supposed to be, and you don't have good stability at the cervical spine to keep the head over the base of support here, then you get overactivity in the more superficial big surrounding musculature. So your tight upper traps and levator scap, tight pecs, and sternocleidomastoid. So here's your weakness in one group causes overactivity in another group. So that overactivity is usually a substitution for some other weak muscle. The big question, to heat or not to heat? As I said before, we talked about viscoelasticity, and when something heats up, then it can stretch better. It has more motion. But the deal is when you put a cold pack on someone, human bodies are about 98.6 degrees at the skin surface, or like 95 degrees. So let's say you're 95 degrees at your skin surface and you're going to put a cold pack or an ice pack on someone. Well, ice is about 32 degrees. Cold packs can be even colder, actually, so you have to be careful. The difference between 95 and let's just call it 35 for fun is 60 degrees. So there's a lot of room for heat to transfer. Because remember, there's no such thing as cold, there's just transfer of heat. So a lot of heat's going to go from the body to the cold pack because the body is 30 degrees warmer than the cold pack. Well, with a hot pack, you're going to put a hot pack on somebody that's about 104 to 106 degrees, and the human body is about 95 degrees. So you have a difference of 9 degrees when you put on a hot pack. You have a difference of, what did I say? 60 degrees when you put on a cold pack. So the change in tissue temperature that occurs with a hot pack and that difference of about 9 degrees is pretty minimal. It also doesn't usually penetrate more than about 1 centimeter below the surface of the skin. So if you're talking about heating up somebody's glutes or somebody's psoas and you're putting a hot pack on it, you're probably not changing the tissue temperature very much. So are you changing the ability to deform that tissue via its either viscoelastic properties or by warming it up, making it more flexible? With the hot pack, probably not, but we'll talk about ultrasound and other deep heating mechanisms. And what ends up happening is you need about a 3 degrees Celsius increase in tissue temperature to change the plasticity of a tissue. So you're probably not getting that with a 9-degree difference with your hot pack that's only going 1 centimeter below the skin surface. So what's the neural influence? Doesn't mean you should never use a hot pack. You have a lot of neural influence here. If a heat pack feels good and you're feeling warmth, then it can distract the patient from their pain or discomfort and make them more tolerant to the stretch. So remember, it's not just about making plastic changes to the tissues. It's about increasing tolerance to stretch. So you can use a heat pack to try to warm somebody up, or at least give them something that feels good and kind of distracts them from maybe pain or discomfort that they're feeling. The other thing you can do is activity. Physical activity is going to warm you up. So if you do some sort of activity intensely enough that you break a sweat, then the body is slightly warmed and you may be a little bit more elastic, a little bit better able to create some plastic changes in the tissue. Then finally, I wanted to point out cryo stretch. We'll talk about this summer, but cryo stretch is where you cool a tissue before you stretch. True story, I don't remember what I was just talking about. I paused the recording because the dog was crying and then my phone rang, and so I don't remember what I was talking about. I was probably talking about cryo stretch, but I'm not sure where I was at with that. So let me start over with cryo stretch. Cryo stretch is where you apply cold before you do the stretch, and really the purpose of that is to either distract the patient from their pain or we'll talk about how pain signals are conducted this summer, but it can be excuse me, the dog is trying to get her toy out from behind the curtains. Okay, now she got it. It should be quiet now. You're trying to block pain signals by applying something that feels warm or cold. So by doing the cryo stretch, you apply cold, it kind of distracts the person from the pain, and you can then stretch them further. And again, you're talking about increasing tolerance to stretch. So it's not always about making plastic changes in the tissue. It may just be about trying to increase the tolerance to stretch so that they can move more easily. All right, on Thursday, we will get into the specific techniques. And I'm at about 35 minutes here, so I'm going to let you go, and you have the rest of the time that you would usually use to come see me in small groups to do your readings. There's a big chunk of reading, so make sure you've actually gone through that before we get to Thursday, and I look forward to seeing you then.